afternoon. It's my pleasure to be here with Professor Patrick Serruys, who just came to perform to talk about the keynote lecture of the Congress. This was about the future of interventional cardiology, what's going to happen in the next 10 years. And for me, it's a great pleasure to be here and to discuss with him the main highlights of the talk. So welcome, Patrick, to the CSC 2022. And my first question will be, one of the highlights is the fact that you think that in the near future you're not going to perform coronary angiography anymore for the diagnostic purpose. What can you tell a little bit more about that?
I said we will stop to use coronary angiography as a diagnostic tool. Of course, it will remain central. The fluoroscopy, the angiography during the procedure will be essential. But really what's happening with the guideline of United States, Europe, NICE, is that the multi-slice CT scan is coming more and more for three reasons. First, for the patient, it's quite pleasant. It's non-invasive. Sometimes we have to puncture 2 times the wrist of the groin because of diagnostic, and then after that, the procedure. So it's good for the patient. We want to reduce some of these redundant tests, you know. You do a thallium scintigraphy, an exercise testing, a dobutamine stress. No, you have the anatomy, the function, and the myocardium at rest. And the third thing, which is important, you can plan. We have already demonstrated that the surgeon can operate without cine angiography. Certainly the interventional cardiologist can prepare their case, angulation, where is the lesion, is the calcium. So I think that that's going to come massively.
Sure, for a stable situation, probably that will be the case. In the acute phase, probably
acute is acute. I mean, we will jump on the patient. STEMI will remain STEMI. Although you never know, you know, you find a new molecule. I didn't talk about that, but imagine that you have a thrombolytic agent which acts more quickly than what we used to have in the past. It can come back, you know. We have seen that kind of comeback in medicine, yeah.
One of the other concept that for me was also struck me most was the categorization of the diffuseness of the disease versus focal disease, and how to treat, or whether do we have to treat diffuse disease, on what will be the best procedure to treat a patient with a diffuse disease.
Right. So I think that diffuse and focal is really the legacy of the physiology in the cath lab with pressure Y and hyperemia and so on. That has been quite nicely replaced by a simple conventional angiography. And that means that adoption could be much more than with the pressure Y, expensive. You have to instrument the coronary artery. So yes, we start to understand that there are different compartments in the heart. There are the big vessel, the focal lesion, you have the microcirculation, and you have also this diffuse disease where you don't know where you could put your stent. And I think that that's a good target for pharma, because when you do the imaging of this diffuse disease, the NOCA as we call it, we realize that there is something in the vessel wall, but not focal, it's all the way. So the best way is to have something systemic to treat that.
Regarding pharmacology, I think you mentioned that the LDL or the hypercholesterolemia is going to be, no longer a problem with the new drugs.
Yeah, I think what you say is correct. Technically speaking, we can bring the LDL cholesterol to 50, even 30, okay? So that's doable, it's proven. And you can get by twice a subcutaneous injection. You know, before coming, I got my COVID number 5, so it will be the same. The problem is when. So I think really you have to identify the people coming out of the college who have the bad gene, okay? And we have to understand and say, oh, that guy probably will develop hypercholesterolemia. will develop diabetes and so, and start to work on them, not only with pill and injection, with the whole education. I mean, Valentin Förster in Madrid and Barcelona has done a job on primordial prevention. He explained to the kid that to eat meat every day is not the ideal things, and many other things. So I think prevention, genetic prevention and treatment, if the normal things, exercise and good alimentation, that's going to be more and more. Because what we do now, look at what we have done this afternoon, calcium in 85, 80, you cannot act on that. You need lithotripsy, you need cutting balloon. That will stay for a long time. I mean, that's not going to disappear tomorrow. But the young people, I think, they have the chance to have genetic prevention and pharma treatment if the rest doesn't work.
I don't know if you have read the book Homo Sapiens from Harari. Because, but the talk you have just presented this morning remind me that he was saying that we are going to reach the immortality, and probably with all you have presented regarding prevention, new drugs for genetic, when you select a patient with a gene, bad gene, then you can change it, and also with the heart and all the holograms, all the how to create a new heart, you can reach the immortality. Yeah. You can. So I recommend the book, but it's really very
I
nice.
think certainly already people are working in the 75, 80, 85. I saw a physician 102 years old the other day, still practicing. So we go further and further. Immortality is something different, of course. That's more. But you're right. I mean, we will have a more productive life if Bismarck has decided that the pension, as they call it, the retirement is at 65. It's just because the blue collar were all dead at 65. So to say you can stop to work and I will pay you didn't cost so much. But now it's a real issue. We have to work longer in our society, and this medical aspect, reducing the health costs, is going to be very important in the future.
Okay, thank you very much. I think it has been a very interesting discussion, and thank you again for coming. Hope to see you in the next editions of the CSC. Thank you very much.
Thank you very much, Emmanuel.